outbreak of H1N1 flu virus. To date, the Center for Disease Control has confirmed 642 cases of H1N1 in the United States and over 40 states, and 2 deaths, including the first adult death. Since the alarm was raised, this administration has acted decisively and responsibly to prevent spread of virus and to prevent undue alarm among the American people. On Tuesday, after more than 545 school closings that sent more than 341,000 children and 21,000 teachers and staff home, federal officials recommended that schools with suspected H1N1 flu cases no longer needed to close. This is good news. Still, public health officials expect this virus will reach all 50 states. Experts also warn that the H1N1 or other viruses may hit harder and stronger by this coming fall. As we look forward, we have an obligation to examine how this unpredictable outbreak has tested schools, child care centers, colleges, and workplaces. In many cases, our morphing public health needs simply don't align with our education and business needs. Today's hearing gives us an opportunity to look at these challenges while they're fresh and to determine what lessons we can learn to prepare for future pandemics. This outbreak has proven that a pandemic can have ripple effects throughout our entire communities. Many schools are still closed but preparing to reopen. Colleges and child care programs have also closed. Teachers and faculties have to figure out how to maintain student learning in the face of closures. There's also no one coordinated system for reporting cases in schools. Education agencies are currently tracking information through county health officials, the CDC, and news reports. There are no specific reporting requirements for districts. As a result, agencies may not have the most complete information about what's happening on the ground. The ripple effect is evident in workplaces too. Employers and workers have questions about how to protect themselves, their families, their businesses, and their jobs in the event of a flu outbreak. While the Occupational Safety and Health Administration has issued guidance and even has some specific standards relevant to pandemic flu, it does not have a mandatory comprehensive standard for protecting workers from airborne transmissible diseases. As we will hear more about today, this is especially troubling for workers on the front lines of pandemics. If nurses, doctors, and first responders and other healthcare workers get sick, they can't treat flu victims or anyone else in the community. If they believe their workplace is unsafe, they may stay home to protect their own health. Sufficient worker protections must be in place to ensure that our healthcare system has the capacity to deal with widespread viral outbreaks. We also want to know what measures businesses are and should be taking to prepare for pandemic outbreaks, including how to deal with sick employees. Current federal leave policies only cover some workers. Paid leave isn't required to ensure sick workers stay home, and the situation where a working parent has child care problems due to school closures aren't covered. Finally, we also need to examine what preventative actions employers and employees should be taking, like providing training on flu prevention, what businesses can do to keep operating if a pandemic hits. Especially in this economy, it's critical to ensure that students can keep learning, businesses can keep providing services to our community. I'd again like to thank all of our witnesses for taking their time out of your vital work in these areas to join us, and I look forward from hearing from your testimony. I'd like now to recognize the senior Republican on the committee, my colleague from California, Congressman McKeon.
Thank you, Chairman Miller, and good morning. Over the past few weeks, many parents and employers have been concerned with the spread of H1N1 flu virus, and rightly so. As most parents know, illnesses such as the flu can spread through a school almost as fast as an email or text message. It's one of those facts of life that parents of school-aged children have had to face for generations. But the H1N1 flu is different because it can be deadly. And with its original exotic and inaccurate name of swine flu, it was natural for parents to become worried. American employers have also been worried. First and foremost, they're concerned about the health and well-being of their workers, but they're also wondering about how this virus might affect their ability to run their businesses. They look at Mexico, where the government ordered a nationwide shutdown of all non-essential businesses for almost a week. In Mexico City alone, estimated losses were put at $88 million a day. If something like that happened in the United States, it would certainly take a toll on working families. And you do not have to be a financial genius to know it would not help America's struggling economy. People also can overreact when they hear about a virus. I'm sure many of us thought about buying face masks after seeing others wear them on TV. I'm also sure a few may have bought one already, just in case. Governments can overreact too. Earlier this week, U.S. health officials reversed their recommendation that schools should close as long as 2 weeks if a student catches the H1N1 virus. Why did this happen? One of the reasons was that officials realized that closing schools would do little to prevent the spread of the disease in the first place. But schools across the nation have done just that. In fact, the Washington Post reported yesterday that at least 726 schools have closed to stop the spread of the flu. But the Post did not report that there are more than 100,000 elementary and secondary schools in the United States. So that means less than 1% of the schools have closed because of the flu. This context would have been helpful because it would have contributed to a better understanding about the threat from this virus. That's what I hope our experts can provide today to this committee and to the American public, a better understanding about H1N1. Their information, calmly and accurately presented with context, will be a great help. We can learn more about this disease, its cause, and most importantly, the steps that can be taken in both our schools and places of work to prevent its spread. Because at the end of the day, I believe we're all committed to the same goal of protecting our children and our coworkers. To that end, I welcome our witnesses today and look forward to hearing from them and learning more about this virus. Thank you, Chairman Miller, and I yield back.
Thank you. I'd like to briefly introduce our witnesses. First, we'll hear from Dr. Ann Chukat, who currently serves as the Interim Deputy Director for Science and Public Health Programs at the Center for Disease Control and Prevention. Before this assignment, Dr. Chukat was the Director of the CDC's National Center on Immunization, Respiratory Diseases, and has spent more than 20 years at the CDC working on immunization, respiratory, and other infectious diseases. Dr. Chukat graduated with the highest honors from Swarthmore College and honors from the Dartmouth Medical School. Mr. Bill Mozelewski is the Assistant Deputy Secretary in the Office of Safe and Drug-Free Schools at the Department of Education. In Mr. Mozelewski's prior role as the Associate Deputy Undersecretary of the Office of Safe and Drug-Free Schools, Mr. Mozelewski was involved in the design and development of drug and alcohol prevention programs, violent prevention programs, and activities, especially as they affect schools and in the school health-related issues. Mr. Mozelewski has a BA and a degree from Political Science from the University of Bridgeport and an MPA from the C.W. Post College. Mr. Jack O'Connell is the Superintendent of Public Instruction in the California Department of Education. Mr. O'Connell previously served in the California State Senate representing the 18th District from 1994 to 2002. And Mr. O'Connell received a BA in History from the California State University of Fullerton and earned a secondary teaching credential from California State University at Long Beach. Mr. Jordan Barab is the Acting Assistant Secretary of the Occupational Health and Safety Administration. He served most recently as a Senior Policy Advisor for the Education and Labor Committee. Mr. Barab is the Special Assistant to the Assistant Director for Labor at the Occupational Safety and Health Administration from 1998 to 2001 and directed the safety and health programs for the American Federation of State and County Municipal Employees from 1982 to 1998. He graduated at Claremont McKenna College in California and received a master's degree in international relations from Johns Hopkins University. Mr. Miguel Antonio Garcia is currently a registered nurse at Kaiser Permanente Los Angeles Medical Center Emergency Department and serves as a labor union contract specialist and workplace safety labor co-chair. Mr. Garcia received a BS in nursing from Franciscan University. Ms. Ann Brockhouse is the Occupational Safety and Health Consultant at ORC Worldwide, where since 1990 she has provided assistance to clients on a wide range of occupational health issues. Ms. Brockhouse holds the BSN from Georgetown University and a master's degree in public health from Johns Hopkins University Bloomberg School of Public Health. Welcome to the committee. Thank you for taking your time to share your experience and your expertise with the members of this committee. As I mentioned to you a little bit earlier, we're here to learn from your experiences over this past month and the lessons that you think you've learned and where you think perhaps there's a misalignment in the system in terms of best informing our population and protecting them. So we look forward to your testimony. When you begin to testify, a green light will go on in front of you, and you will have 5 minutes for your formal testimony. At 4 minutes, an orange light will go on, and you want to think about wrapping your testimony up, and then there will be a red light. But we want you to complete your thoughts in the manner that you think is most important to us. Dr. Chukat, we'll begin with you. Welcome.
Thank you. Good morning, Chairman Miller, Ranking Member McKeon, and distinguished members of the committee. I'm Dr. Ann Schuchat, the Acting Deputy Director for Science and Program at the Centers for Disease Control and Prevention, and really appreciate the opportunity to talk to the committee this morning. I'll be updating you about what we know, what CDC is doing, and some of the steps that are in place, and really appreciate the chance to testify with the distinguished colleagues. First, I just want to say that my heart and the hearts of CDC really go out to the people in the communities that have been affected here in the United States, in Mexico, and around the world, both directly from the virus and then indirectly from some of the interventions and the impacts they've had on families and communities. We know that our nation's 7.6 million workplaces and over 126,000 schools and other childhood settings have been facing the challenges of this outbreak. We shared the concern of people across the country, and we're responding aggressively at the federal, state, local, tribal, and territorial levels to understand the complexities of this outbreak and to implement effective control measures. Our aggressive actions are possible in many respects because of investments and support of the Congress and in U.S. pandemic preparedness, which has provided us with many of the tools we're using to detect, track, and control the impact of this outbreak at CDC and at state and local health departments across the country. Influenza viruses are very unpredictable. It's hard to anticipate the course that this outbreak will have with any certainty, either this spring or in the fall, at the usual return of the influenza season. We do expect to see an increase in the number of cases, the number of states affected, and we also expect to see additional deaths and hospitalizations. We're carefully monitoring the severity of illness caused by this virus. While preliminary evidence is encouraging, we understand that this too could change. Amid this uncertainty, our goals are to be clear in communicating what we do know, acknowledge the uncertainties, be clear about communicating what we are doing, and what individuals can do themselves to protect their families and their communities. Influenza arises from a variety of sources, and in this case, we've determined there is a new or novel influenza A H1N1 virus that is circulating around the globe that contains genetic sources from 4 different virus sources. We've been able, within just 2 weeks, to identify this novel virus, understand its complete genetic characteristics, and compare the genetic composition of specimens from U.S. patients to others from around the globe to watch for mutations that may change the properties of the virus and how it behaves in people. We've also very quickly developed and then deployed test kits for use in the widening network of laboratories that are responding to this outbreak. These steps, along with the capacity that is in place as a result of effective planning over the last few years, have allowed for the rapid diagnostics and epidemiology that contribute to a clearer understanding of transmission and severity of illness caused by the virus. These scientific accomplishments have provided the basis for an evolving set of responses that greatly enhance our nation's ability to address this threat. CDC has determined that the virus is contagious. It's spreading from human to human. It appears to spread with similar characteristics to seasonal influenza virus through coughing and sneezing, through human-to-human contact. Sometimes people may become infected by touching something that has the flu viruses on it and then touching their mouth or nose, but there's no evidence at all that this virus can be acquired from contact with pigs or from eating pork or pork products. Aggressive actions are being taken here in the U.S. as well as around the world. We're working very closely with state and local public health officials around the country on the investigation and on implementation of interventions such as infection control measures. We're providing both technical support on the epidemiology as well as laboratory support for confirming cases. We're also working with international partners on the outbreak, including a collaborative effort in Mexico, really the epicenter of the problem, to better understand the outbreak and enhance surveillance and lab capacity there. and we're working closely with Secretary Napolitano and our other federal partners to ensure our efforts are coordinated and effective. CDC has issued numerous health advisories for individuals, healthcare practitioners, schools, and communities, and these continue to evolve as our understanding of the situation changes. In fact, a key message from CDC is that there's a role for everyone to play in the outbreak. At the individual level, it's important for people to understand how to prevent respiratory infections. Frequent hand washing is a good idea. If you're sick, stay home. If you're sick, don't get on an airplane or public transport. Keep your kids home from school if they're sick. Taking personal responsibility can help reduce the spread of this virus as well as other respiratory infections. But the path of this outbreak is unclear. As I said, influenza is unpredictable, and we need to be prepared for the potential return of this virus in the fall, perhaps in a more severe format. It's important for public health officials to continue to think about what might be needed if the outbreak deepens in the communities where you work. It's also important for businesses, schools, and local governments to anticipate those types of changes. Schools and childhood settings, including Head Start and child care programs, play a critical role in protecting the health of their students, staff, and the community from contagious diseases, including this novel H1N1 influenza. About 1 out of 5 Americans spend considerable time in one of the more than 90,000 school buildings on any given school day. Millions of adults work in school and childhood settings, and many millions more are parents or guardians of school-aged children. While CDC has made scientific recommendations about how schools can deal with this virus, the authority for decisions regarding school dismissal resides at the state and local level. We at CDC applaud the collaborative efforts of schools, superintendents, Head Start and child care directors, county executives, mayors, governors, et cetera, who are on the front lines of this epidemic. The emergency preparedness work that communities had done before this outbreak has been essential in the response. That includes the 600 local education agencies that have been working with our colleagues in the Department of Education through their Readiness and Emergency Management for Schools program. Without that sort of considerable advanced planning and ongoing exercising, we would have been much less prepared for this outbreak and the ongoing response.
Dr. Schuchat, I'm going to ask if you can start to wrap up.
Sure.
Thank you.
Absolutely. CDC's NIOSH is leading the agency's efforts to minimize effects on the epidemic and working to disseminate guidelines. I do want to stress that as we learn more, we try to use the science to inform changes in guidelines and try to work collaboratively across government and with partners before we issue new guidelines. We in the government can't solve this problem on our own, and we do need the cooperation of other sectors. I just want to conclude by saying we don't know exactly where this virus will go, but we have never been as prepared as we are today based on the investments of the past few years. Thank you.
Thank you. Mr. Marjoleski.
Good morning, Mr. Chairman, Congressman McKeon, and other distinguished members of the committee. I'm Bill Marjoleski, Associate Assistant Deputy Secretary at the Department of Education's Office of Safe and Drug-Free Schools. I want to thank you for the opportunity to appear before this committee today to provide you with an overview of the Department's actions during the 2009 H1N1 flu outbreak. This morning, I want to provide an overview of the situation regarding school closings, summarize some basic principles that form the foundation of our response efforts, and if time permits, conclude with some of the actions we've taken recently to help schools and institutions of higher education to respond to the current outbreak of the H1N1 flu virus. Let me start by stating that the situation regarding schools remains somewhat fluid. That is, we have some schools opening while others remain closed. In the 8 school days we've collected information on school closings, we saw daily changes. On Monday, April 27th, 22 schools in 3 states had announced decisions to close for reasons related to the H1N1 flu. There were approximately 15,700 students impacted by those closings. By Tuesday of this week, the number of closures stood at 726, representing 24 states and the District of Columbia. And these closures affected approximately 468,000 students. On May 5th, the Centers for Disease Control and Prevention announced revised guidance on community mitigation that advised that students with flu symptoms stay home from school, that schools would confirm their suspected cases of the flu, not close. While it's been less than 48 hours since this revision was announced, we've already seen considerable change. Approximately 140 schools with 100,000 students reopened yesterday, and more are expected to reopen today. Overall, the school closures affected a relatively small number of students and staff, but created a considerable amount of concern. Although the scientists at CDC are cautiously optimistic about what they are learning about the virus, we must remain alert to the possibility that the nature of this current outbreak could change. We'll continue to rely on 5 key principles as we work to help schools and institutions of higher education prepare for and respond to the range of crises, including a pandemic. First, our chief concern will continue to be the health and safety of students, faculty, and staff. Federal education statutes and regulations should not be an impediment to closing schools for health reasons. We are ready to consider requests for waivers related to the flu to the extent of the Secretary's waiver authority. Next, we recognize that effectively managing crises such as the H1N1 flu outbreak requires many different agencies and organizations working together. The Department of Education can't do it alone. We'll continue to collaborate with our colleagues from the Department of Health and Human Services, including the Centers for Disease Control, the Department of Homeland Security, and other federal agencies to capitalize on the value expertise they possess. Working with them is also essential in ensuring that we provide a coordinated federal response. Next, we need to keep in mind that many of the most difficult decisions concerning response to the current flu virus must be made by state and local officials. While state and locals have a lot to do, a lot has already been done. States and localities, as well as the federal government, have already invested a significant amount of effort in planning for the pandemic flu. Every state has a pan-flu plan, and every plan contains an appendix describing the roles of schools during an epidemic. We'll continue to build on those planning efforts and support state and local education officials. Next, while the current outbreak of the H1N1 flu is the issue that brings me before the committee today, we believe that the best approach for schools and institutions of higher education to take in preparing for an outbreak of an infectious disease or any other crisis situation is to develop an all-hazards plan that addresses a variety of crises, from intruders and accidents to school shootings and the flu. Finally, our decisions about how schools and institutions of higher education are to deal with a crisis are based upon the fact that while crisis planning for schools has to consider the health and welfare of students and staff, the plan also needs to consider the educational needs of students. Crisis planning can't exist in a vacuum. Consistent with these general principles, we've taken several actions in the past week to support schools and institutions of higher education. In addition to tracking information about schools closures, we, in coordination with the Centers for Disease Control and Homeland Security, provided opportunities for school officials to hear up-to-date information directly from scientists at CDC and oppose questions by hosting 3 conference calls. And I'm happy to say about 3,000 conference lines were used during those 3 calls. We also developed and posted detailed guidance responding to a number of issues specific concern to the schools and institutions of higher education, including school closures, and developed a mechanism for school and other officials to submit questions concerning the flu to the department. And we're using these questions to help us better understand the challenges that schools and colleges are facing to identify issues on which we can develop and post additional guidance. I hope that you found this overview helpful, and I'd be pleased to answer any other questions you may have. Thank you.
Thank you very much. Jack, welcome to the committee.
Thank you very much, Mr. Chairman. Thank you, Mr. Chairman, and Congressman McKeon, and all the members of the committee. A pleasure to be here to address the recent outbreaks of the H1N1 flu in California, specifically the impacts that it's had on our public education system. I'm pleased that the Centers for Disease Control has recently determined that the automatic school-wide dismissal of all of the students at a particular school need not occur with even the 1 confirmed or highly suspicious case of this virus. Clearly, in California, local health officials have the ultimate jurisdiction to close our school and to dismiss all of our students. I'm pleased that this new guidance, as more and more information becomes available and better known, will allow more of our students to remain in school on task, preparing for their successful future. I also appreciate greatly the initial concern for our school children and our entire staff at Education that led to the recommendation of dismissing all of our students from any campus that had a confirmed or even a suspected case of this virus. CDC still wants, as you have heard earlier, all of our steps to be taken. Those steps, and try to repeat them all the time, to wash hands frequently, duration of at least 20 seconds with soap and water. If you're going to cough or sneeze, the students have taught me, Mr. Chairman, do the Dracula sneeze into your arm, kind of slowly into the crux of your elbow. And obviously, as has already been stated, if you're sick, stay home, including from school. I'm continuing to encourage our schools, our school districts to stay in close contact with local public health officials. We need to do an even better job of monitoring, as the chairman pointed out, the number of cases that we have, the number of illnesses, and we need to do a better job of tracking absences that also are directly attributable to the flu. If I might briefly, Mr. Chairman, I'd like to walk through the steps that we have taken during the last couple of weeks at the California Department of Education with our school community and our health community since the outbreak of the H1N1 virus. We did stay in very close contact with both state and local departments of health in California, with our schools, our school districts, including our charter schools. Within hours of the first alert of the H1N1 virus, my department issued a release to every school district about the precautionary steps that students need to take in order to make sure that they remain safe. We have numerous information available, posters, sample letters, easily downloadable to schools, how to prevent and how to secure through precautionary steps for our students and our staff to remain safe. And again, this is to wash your hands, posters, and how to sneeze, and if you're sick, stay home. We've also received some reports from some schools in California, Mr. Chairman, that the soap was not available in either some restrooms for our students and our staff. Clearly, that's unacceptable. We need to have soap or an alcohol-based hand sanitizers available at all times to our schools, to our students and our staff. We also developed at the Department of Education a special link on our website to keep school districts informed of those cases that we knew about, what schools were in fact dismissed, and also all press releases that were issued by either the educational community or the public health community in this area. And then just last Friday, we conducted a statewide conference call where we asked and invited each of our over 1,000 school districts to have the appropriate person online to talk and to ask questions to Dr. Bonnie Sorensen, who is a Deputy Director for the California Department of Public Health. Every school district and almost every county was invited. Every county was invited. Dr. Sorensen had an opportunity to brief school district officials on the latest guidance for potential dismissal of all students at their schools as it related to the H1N1 virus. Numerous questions were asked. Schools wanted to know the most recent information and also trends. As of Tuesday, just 2 days ago in California, 37 public schools had been ordered shut by local public health officials. And to make Congressman McKeon's point, that's 37 out of over 9,000 schools in the state of California. I believe our schools are much more relieved by the most recent guidelines by CDC and also California Public Health. We all understand that this clearly is an evolving process. Guidelines would need to change and update for more and more information. I've always stressed the importance of the school community to work closely with county public health because they ultimately have a final say on dismissal of students. I also wanted to share with you a major topic of concern for school districts. How would these school closures or the increase in absences when parents choose to keep their students home, fearing a potential impact, affect our state standardized test? This is the testing window in California today for our standardized testing, as well as the California high school exit exam. We in California are trying to address this on a case-by-case basis. We're trying to make the accommodations necessary for the schools and school districts, and we are working with our contractors and our vendors. We've also communicated with the Federal Department of Education regarding this issue on how school closures would be impacted, for example, on participation rates, to make sure that we meet both our academic performance index and adequate yearly progress rates, and also reporting schedules. Some participation rates may in fact be affected by parents who just simply keep their kids home out of fear. The response from the federal department has been very, very helpful. They understand, very empathetic, and they've committed to work with us, and we're most appreciative of that. And then lastly, I wanted to make an issue too briefly, if I may. We need to have better communication between the field and our state offices in my department. I believe we do need to establish a system, really protocols, so that we know how many schools, how many students have actually been affected. We want to develop easy reporting procedures so that we can make better decisions based upon how many students we're actually talking about. And finally, Mr. Chairman, I believe that this issue also highlighted, in my opinion, again, a real need for school nurses, school health professionals at the school site. In California, as I mentioned, over 9,000 schools, 6.3 million students, over 330,000 teachers, and yet we have only 2,844 school nurses. That ratio is 2,227 students to 1 school nurse. That's one of the largest ratios in the country. Given the recent budget reductions in many local school districts, many schools have been left without sufficient healthcare professional personnel, and perhaps more school nurses could have helped us with early detection and even prevention. Again, thank you for the opportunity to be here. I greatly appreciate both the Obama administration and this Congress for helping us improve our educational delivery system throughout California and indeed the entire nation. Thank you, Mr. Chairman.
Thank you. Jordan?
Thank you. Chairman Miller, Ranking Member McKeon, and members of the committee. Thank you for this opportunity to discuss the Occupational Safety and Health Administration's strategy for the protection of American workers from this new strain of Influenza A 2009 H1N1. During an influenza pandemic, as we all realize, the workplace can be a source of transmission just as in other settings. Fortunately, because OSHA has previously prepared for a possible outbreak of pandemic related to the avian influenza virus, the agency is now fully prepared to address the dangers of the 2009 H1N1. The full range of OSHA's training, education, enforcement, technical assistance, and public outreach programs will be used to help employers and workers protect themselves at work. Preparation is critical. Proper planning will allow employers to better protect their employees and reduce the impact of the pandemic on society and the economy. OSHA has developed guidance to help employers determine the most appropriate work practices and precautions to limit the impact of the influenza pandemic. Because pandemic-related health and safety risks are greater in certain workplaces, OSHA is focusing its direct efforts on educating employers and employees in high-risk exposure categories. OSHA uses its occupational risk pyramid for pandemic influenza, which is projected on the screen, for both its own determination and for employers to determine those workplaces that are at higher exposure risk level. The pyramid visually demonstrates that only a small portion of workers are at the highest exposure risk level. In response to the 2009 H1N1 outbreak, OSHA's current outreach efforts are primarily focused on high-risk and very high-risk workers, those who have direct contact with infected individuals as part of their job responsibilities, such as healthcare workers and first responders. OSHA recognizes the importance of protecting healthcare workers on whom this country relies to identify, treat, and care for individuals with the flu. Our frontline healthcare workers are the foundation upon which our healthcare system is built. If they are not able to work due to illness or unwilling to work due to fears for their health, then individual patients and the country's entire healthcare structure will suffer. To help healthcare employees and workers prepare for an influenza pandemic, OSHA has developed a pandemic flu preparedness and response guidance for healthcare workers and employers. This publication provides valuable information and tools which healthcare workers and healthcare facilities can use to protect their employees. If we expect our healthcare workers to come to work each day during a pandemic, then their employers have a responsibility to ensure that they have the best protection, including engineering controls, administrative controls, appropriate respirators, and other personal protective equipment. And I also want to remind you that we can't forget the custodians, security guards, and administrative employees and maintenance workers who support these high-risk workers. While generally not at high risk themselves, if we're to expect them to report to work every day to carry out their critical functions, they also need to be educated about the virus, their level of risk, and situations where they are at risk and how they need to protect themselves. It's our expectations that most of this nation's hospital and healthcare institutions where workers are clearly at exposure risk are fully prepared to provide that training, equipment, and protection. And if they are not now prepared, that they are working hard to finalize plans to ensure that they will soon be ready for an outbreak. These plans should include ordering and stockpiling respirators and other personal protective equipment, conducting fit testing, medical evaluation, and training for those required to wear respirators. OSHA and CDC have distributed extensive information on how to protect workers. Employers play a key role in protecting employees' safety and health, and OSHA will continue to provide them with the technical assistance they need. But OSHA also stands prepared to use its existing authority to aggressively enforce safe work practices to ensure employees receive appropriate protection. In appropriate circumstances, OSHA will use the General Duty Clause of the Occupational Safety and Health Act, which requires that employers follow the practices that public health experts agree are necessary to protect workers' health. OSHA also has standards addressing housekeeping and personal protective equipment, as well as a respirator standard that requires the complete respiratory protection program for employees. It's the employer's responsibility to ensure that we have the protection and training that workers need: when to wear a respirator, what kind of respirator, how to get the respirator fit tested and wear it properly, when to wear gloves, and how to put on and take off personal protective equipment. OSHA is also developing additional information for workers and their employers in the pandemic influenza, including fact sheets and quick cards that are appropriate for workers to use. Many of these materials are on our website and also on pandemicflu.gov. Mr. Chairman, I'd characterize this situation for the workforce just as the President described it for the nation: cause for deep concern, but not panic. I'm very confident in the expertise of OSHA's medical, scientific, compliance assistance, and enforcement personnel. OSHA is prepared to answer the threat and will protect the workforce. I will keep this committee informed on OSHA's efforts to protect working men and women from the pandemic flu exposure. Thank you very much.
Thank you. Mr. Garcia.
Hi, my name is Miguel Garcia. I'm a registered nurse. Chairman Miller and other members of the committee, thank you very much for asking me to come and testify. Because I work in the emergency department at Kaiser Permanente Los Angeles Medical Center, I'm on the front line of fighting this current outbreak of the 2009 H1N1 influenza. I am testifying on behalf of UNAC UHCP, who is a part of ASME, which represents 1.6 million members, including 360,000 healthcare workers. In order for nurses to be able to treat and protect patients, we must be protected first. My employer, Kaiser, has taken a positive collaborative approach towards flu preparedness through a strong labor management partnership. Kaiser has taken an organizational approach to how we care for our members, our patients, and our staffs. In many respects, my employer is the exemplar of preparedness. However, many of the employers have not taken the necessary steps and prepare and protect healthcare workers from the flu pandemic or the current outbreak of the H1N1 flu infection. A recent survey conducted by my union and other labor unions representing healthcare workers found that more than 1/3 of the respondents believe that their workplace is not ready or only slightly ready to address the health and the safety needs necessary to protect healthcare workers during this influenza crisis. The survey also found that given this lack of readiness, 43% of the respondents believe that most or some of their coworkers would stay at home. Importantly, Kaiser does provide me an annual fit test for the N95. An N95 respirator is different from the surgical mask. The surgical masks are designed to prevent the person wearing the mask from contaminating the external environment with fluid and air droplets when a person coughs, sneezes, or talks. Surgical masks aren't designed to have a tight seal on your face. They leak around the mask while you inhale. Surgical masks do not protect you from breathing of viral particles that are suspended in small droplets. Respirators, on the other hand, are specifically designed to protect the person wearing the respirator from inhaling into their lungs viral particles that are suspended in the air. Respirators, unlike surgical masks, seal tightly around the face and prevent leakage of air inside the respirator that could then be inhaled into the lungs. Currently, there is no comprehensive federal standard that requires employers to protect healthcare workers from airborne hazards like the H1N1 or tuberculosis. There are OSHA and CDC guidelines, but to date, these guidelines have only been voluntary. Patients who have the H1N1 flu are likely to go to the emergency room. To treat and to care for these patients, healthcare workers and first responders must be protected. We need more than guidelines from OSHA in order to make sure that all employers provide consistent protections to healthcare workers during this flu pandemic. We need to have clear rules for all healthcare employers to follow. We do not know with certainty the path that the 2009 H1N1 influenza virus will take, but we do know that it's a recognized hazard. OSHA should use existing standards covering respiratory protection and personal protective equipment and use its authority to enforce those standards in healthcare settings where workers may be exposed to the flu virus. OSHA has authority to make its current pandemic influenza guidance for healthcare workers and healthcare employers mandatory. Taking such a step quickly would send a clear signal to the public and healthcare workers that the government is proactive in protecting the workers who are needed to care for the sick in our communities. Protecting these workers will preserve our surge capacity to treat the infected. In addition, we need OSHA to move as quickly as possible to develop and issue a mandatory comprehensive standard to protect healthcare workers from airborne infectious diseases, similar to the existing comprehensive standard on bloodborne diseases. Thank you for listening, and I invite your questions.
Thank you. Ms. Brockhouse.
Good morning. On behalf of ORC Worldwide, I would like to thank the committee for this opportunity to discuss some of the steps businesses are taking to ensure that workers are protected from the H1N1 virus. Over the past few days, there appears to be a growing consensus among the experts that this new virus is, at least for now, a less serious threat than originally feared 13 days ago, although, as has been mentioned, this is no time for complacency. But the story could have been very different, and there are a number of important lessons that can be learned from our observations of the actions taken by businesses as the situation rapidly evolved. The first lesson we'd like to highlight is that advanced planning counts. ORC Worldwide conducted teleconferences on April 28th and May 5th for our network's membership of several hundred multinational companies from diverse industry sectors to share critical information on strategies for responding to the H1N1 outbreak. Additionally, on May 1st, ORC sent a survey questionnaire to the health, safety, and human resources functions of more than 600 ORC client companies regarding aspects of their company's preparedness and response activities. We learned useful information from these teleconferences and from the 89 companies that have responded to our survey. First, an overwhelming majority of those responding to the survey have a business continuity plan or pandemic preparedness plan in place to respond to global outbreaks of flu or a full-blown flu pandemic. Over 60% of the companies responding implemented changes to business travel practices as a result of the outbreak. Communication to employees in the form of health briefings and dissemination of contact numbers for medical advice is reported by the majority of respondents. Almost half of those responding had instituted policies requiring that employees returning from areas with confirmed cases of H1N1 stay at home for a period of time before returning to work. We learned that existing plans were often geared to worst-case scenarios, and plans had to be adjusted as new information about the severity and scope of the H1N1 outbreak became available. Additionally, communication and coordination across functions has been a challenge in some companies. Preparedness planning must include regular communication across critical functions such as health and safety, human resources, security, legal, and others, and must be established well before a crisis occurs. Companies tell us that planning initiated in response to the threats of SARS and avian flu and refined over time has proven to be practical and useful in the situation we find ourselves in today. Effective plans contain feedback loops, allowing for evaluation of their effectiveness and mid-course corrections. Plans must be scalable, flexible, and adaptable to rapidly changing conditions. Lesson 2 is that timely and consistent government information and guidance is critical to effective response. Clear and timely government information at the federal, state, and local level has proven to be critical to company efforts to respond effectively to this outbreak. Frequently updated information and guidance from the CDC has been invaluable. Preparedness planning activities related to avian flu and bioterrorism by state and county and local health departments in California provide a particularly compelling example of how public-private partnerships and outreach to the business community have helped inform the business response to the current public health emergency. OSHA's outreach to the business community this week was also very welcome. particularly heartening is the commitment by OSHA, NIOSH, and the CDC explicitly expressed, and other agencies, to coordinate the response activities and eliminate any inconsistencies in messages. On-the-ground coordination is necessary in many more jurisdictions. This is a two-way street, in our opinion, and both business and government entities at all levels need to look for new ways to effectively connect and collaborate on public health preparedness issues. Efforts to use novel ways to deliver critical public health information to a vast and diverse audience must continue. CDC's use of Twitter is a great example of this. And lesson 3, making pandemic flu planning part of an overall safety and health management system optimizes protection of workers and helps to ensure business continuity. A basic foundation for effective worker protection is the establishment of a comprehensive system for managing safety and health performance, focusing on elimination of injuries and illnesses through a continuous process of identifying, assessing, and reducing risks. Companies with such systems in place and with the active engagement of senior leadership are in the best position to effectively engage in preparedness planning, keep plans up to date, and take decisive action in response to public health emergencies such as the current H1N1 outbreak. ORC looks forward to working with the committee as it continues to evaluate the key components of effective programs and policies to ensure worker protection, and I'd be happy to answer any questions that the committee might like to pose.
If I might, if you just take 30 seconds to explain ORC.
ORC Worldwide is a human resources and health and safety consulting firm. For more than 35 years, our Washington, D.C. office has focused on occupational safety and health consulting, and I'm with the ORC D.C. office.
So this is one of a service provided by ORC to its clients, to its members.
ORC advises its clients on best practices in worker protection, and also helps our clients share information with each other so that in diverse industry sectors there can be a sharing of information about what works best in terms of worker protection.
Okay, thank you. Thank you. Well, thank you all very much for your testimony, and I think your testimony helped put a lot of this into context. I think when we look at it in the communities that we represent, you see a lot of conflicts. Do you send the kids home? You don't send the kids home. If you send the kids home, is there anybody home to take care of them? If workers leave, can the business keep running? Or do you want sick people at work? I mean, this isn't a clear-cut decision on anybody's part because there's these conflicts about how you handle it. Do you want workers to come in if they're sick, or do you want them to stay home? Do I want to go in if I'm not sick, if other people are sick? I need information about my environments, I guess, is what I'm saying. And people are sort of pushed into the position of thinking, what's the safer environment for me or my children, my employees, what have you? What do I know about staying home, being in the community, being at work, being at school that's helpful to me? Jack, you mentioned you thought there was some gap in community, or you needed better communications between the state and the districts. Is that what you were suggesting?
It is, Mr. Chairman, and I think so that we can share the information that we have. And I would also say the media has a role to play, and in my opinion, an obligation and responsibility to let people know, for example, the severity of this particular strain. And that's why, my comments earlier in terms of we're pleased with this most recent decision, that sends a signal that this strain has not been considered as serious as that in central Mexico that has led to so many illnesses and so many regrettable deaths. Yes.
I see. Jordan, on your pyramid, you talked about those who are at the top and high risk and very high risk workers. And how do you and when do you put those workers into that category when you go through an episode like this? At the beginning, you have an influenza, you don't know a lot about it. Do you immediately decide the so-called first responders in hospitals, doctors' offices, public health clinics, that they are immediately put into this category in terms of being watched and providing information? Or does that happen later when you know more about the influenza? How is that coordinated?
First of all, we take our lead in terms of the seriousness of the virus and the nature of the virus from the CDC. We are very involved in a number of different committees and daily or more than daily phone calls, and keep very close track to how the virus is progressing. But in general, our advice to the high risk and the very high risk workers are pretty consistent. If you're in contact with a person who's infected, confirmed to be infected or suspected to be infected, you should take all the precautions that we recommend. And again, the engineering controls, the administrative controls, but also the respirators and the respirator program.
But is that a phased-in consideration as you start to get more information? I mean, would you make a decision that healthcare workers in the point of contact should start protecting themselves, or should they, which could be washing your hands, but it could also be making a decision that you better be wearing a respirator? How is that information transmitted?
Based on what we know about seasonal influenza and about respiratory viruses, healthcare workers were considered a high-risk group in terms of very close contact with people who were actively ill.
That's a general understanding.
For this particular infectious disease, that would be. The other thing to say is that in any epidemiologic investigation, a very early question is, who is at higher risk? Which are the groups that are seeing the illness disproportionately? So one of the reasons CDC has people working with state and local health departments in a number of affected areas and people on the ground in Mexico is to rapidly learn as much as we can about what's going on. Conflicting reports from different places, but trying to recognize quickly who will be at risk. This outbreak that we're seeing here, younger people had been more at risk than in seasonal influenza, so that was an early focus.
Could that, and I assume that's not confined just to healthcare workers. Teachers could find themselves in that category if you found evidence that justified that. People in a place of employment, certain types of employment perhaps could find themselves at high risk.
Absolutely.
Okay.
We would be looking at the epidemiologic information and trying to adapt rapidly to it.
You mentioned, Ms. Brockhouse, that a significant number of your clients have business continuity plans, and that's done for all different kinds of eruptions or interruptions.
Absolutely, right. The companies, and we're talking about large companies, mostly multinational companies that have learned over time that in order to ensure that that in the event of a natural disaster or all of the things that you can imagine that could interfere with a company being able to do its business, that they have plans in place that anticipate ahead of time what might happen and what the company will do in response. And for many companies, pandemic preparedness is now a component of an overall business continuity plan that would be in place to respond to all sorts of potential interruptions of business.
Thank you. Mr. McKeon.
Thank you, Mr. Chairman. Doctor, you mentioned seasonal flu. So we have seasonal flus every year. Do you know how many deaths we have annually from seasonal flu?
Right. Seasonal influenza kills an estimated 36,000 Americans each year. There are 200,000 hospitalizations and millions of infections. What's different about this particular outbreak is we have a completely new influenza virus that we don't expect there is large population protection against. With seasonal influenza, a good proportion of the population is naturally protected by years of experience with these viruses, and many more are protected through the vaccination efforts we make, with more than 100 million people getting vaccinated each year. So with a new influenza virus, the big fear is that if it has a certain amount of severity, you have the whole population at risk, and you could get much greater, even a greater burden than that 36,000 deaths a year.
So that was what we were afraid of?
Well, I think that we had, at the beginning of this, we had a completely new virus. We had reports from Mexico of severe disease in healthy young adults, and we had information about things moving quickly. We acted aggressively and actively to try to take steps to decrease the risk of illness and death and slow the spread. The idea of slowing the spread is to stretch things out so that the healthcare system won't get overwhelmed and to buy time for production of a vaccine should that be necessary. So that's the original strategy.
The seasonal flu that kills 36,000 people every year is the same year after year, and this one is a new one.
Well, the seasonal influenza viruses shift a little bit. They are just a little bit different each year, and we make up a new vaccine each year because of that change. But with a totally new virus, you have what's called a pandemic potential. You can get much more disease.
What does pandemic mean?
A pandemic of influenza is defined by a strain that is able to cause severe disease in people, that it's totally new and you don't expect population protection, and that it's easily or efficiently transmitted in a sustained way. The H5N1 bird flu strain that we've been seeing, that was a totally new strain that there wasn't population immunity to, caused very severe disease, but it hasn't yet been able to cause this efficient transmission. What we saw with this H1N1 strain was a virus that was apparently being very easily spread, just like seasonal flu is easily spread, and the uncertainty that we've had and continue to some extent to have is just how severe it will become, or whether it will mutate and become even more severe than it is so far. So that's why the World Health Organization has really been on this high alert, and why the public health community has been acting so aggressively.
I had an uncle that died as a baby during the flu of 1918. That was a worldwide pandemic that killed how many people?
You know, here in the U.S., we think it was 500,000 people, and up to 50 million worldwide. It was just a massive, massive problem. And that is really what we often in our planning talk about as the worst case scenario. It's a big focus of an early response, such as we've been having, to characterize the severity of the strain and understand what's going on. A cautionary note is that with the 1918 pandemic strain, it caused illness in the first spring of 1918 that was moderate, but it came back in the fall in a much worse form. And so, you know, they didn't have antiviral drugs then or couldn't make a vaccine, and healthcare wasn't what it is now. But it wasn't over just in the spring. There was really a second wave that was more deadly than the first.
One of the concerns that I had when I first heard about this a couple of weeks ago, it was everywhere in the media, and it was I was worried that it was scaring people inordinately, and yet all they said to do was wash your hands, and unless you really need to go to Mexico, don't go. I mean, it sounded like in one way it was overkill, and another way it was, well, you know, it's not that serious. And I guess that's a fine line. I think what you were doing and the other things that we heard from the committee were very important. I'm wondering if the media, as they tend to do, goes a little overboard, and some people were scared, which is maybe why some schools were closed, some businesses maybe had overly concerned. I guess this is a fine line that you have to deal with on every disease, but when I think about the annual flu that we just kind of take for granted, I didn't realize that 36,000 people die every year, and we've had 2 deaths now. One, there's a person that came into the country already sick. I wonder where we, you know, how we handle that as regard to how thoroughly we scare people versus, you know, what actually finally ends up happening. I know the president asked for $1.5 billion to address this. Is that for money that you're already spending, or for schools that have lost money, or, you know, or we haven't even really dealt with this yet in coming up with that money, but I guess I still have some questions, but I really appreciate the panel and thank you for your input.
If I might take a privilege of the chair, and then I'm going to go to Mr. Andrews. Could you explain the process? Because I think Mr. McKeon has touched on an important point. The idea that schools were closed and that schools were open, there's sort of a kiss-off. Well, they just don't know what they're doing. And could you just describe the environment and how you arrive at that decision, both the first and the second decision, the judgments you have to make? Because I think it's an important point, because you don't quite know. There's two schools of thought out there when this is all boiling around in the media.
Yeah, at CDC, we've been acting very aggressively to get information out to local and state decision makers and to provide guidance that will inform local or state decisions. An issue like school dismissals is under the authority of the local, usually local, sometimes state groups. We issued initial guidance on school dismissal, recognizing that local decisions may differ from the national recommendations because there's much better information on the ground about both the circumstances and where students or teachers may need to go, and what would be the consequences. Our original guidance was issued, you would probably say very aggressively, about if you have a case recognized, you should consider dismissing students. This was because the planning and modeling and understanding of the role of school dismissal suggested that it's very early in a response where that would be effective at reducing spread by taking students who congregate together in a school and having them stay home with just the family contacts could really reduce the spread. What we found as we went on was that this virus was spreading in the community already, and that the disruption of the school environment was not really being justified by the intervention that we were recommending. But I would say that the decisions to issue guidance will vary as information changes. The role of school dismissals was planned for a very severe new virus. We didn't have adequate information at the beginning to rule that out. Right now, we feel that what's circulating right now, it's not nothing. It has severity in some people, but that it wasn't that Category 5 type of pandemic strain that we had feared. So we took early interventions, we respected local variability, and really supported the locals who were making tough decisions with the information on the ground.
Thank you. Mr. Andrews.
Thank you, Mr. Chairman, and thank you for having this very timely hearing. I'd like to thank each member of the panel. I know we're not out of the woods yet by any stretch of the imagination with this pandemic, but I think each of you in your own way has done a very good job responding to this situation, in informing the public and protecting the public. And again, I know we're not out of the woods, but I think you're off to a really promising start, and we appreciate that. We do. Dr. Shushat, did I pronounce your name correctly?
Shukit?
Shukit, I'm sorry. Dr. Shukit, on page 8 of your testimony, you talk about the 2 drugs that appear to be successful. I will not attempt to pronounce them. Since I've already botched your name, I won't try to do the drugs. You say that acting quickly after you identify the virus and its potential impact on the population, you've released 1/4 of the state's share of antiviral drugs and equipment to be used pursuant to help the states prepare to respond to the outbreak, and that the deployment of the stockpile was completed by Sunday. To whom are these drugs distributed? How are the drugs administered to people who need the help?
The Strategic National Stockpile antiviral drugs were targeted primarily for use in treatment, 44 million doses or regimens for
But what I'm asking is, where does the treatment take place?
Right, so they are distributed from us to the state health departments,
right,
or the project areas, and each state has submitted a plan of how they intend to distribute the antivirals. Some states would be going through regular pharmacies, some states would be using the public health settings. We
right.
really, in the pandemic planning efforts, required each state to think this through with
Do they also use physicians' offices?
Some of them do it that way, so it's really flexible in terms of what will work with their population setting.
One of the facts that really struck me about Mr. O'Connell's testimony, an amazing statistic. For every 1 school nurse in California, you have 2,227 students. Wow. So if this program were in some way to be set up through the schools, it's certainly not going to succeed given that kind of ratio. What other kinds of public health, put to you this way, if you had to get these drugs to a lot of people in a hurry, how do states typically do that?
You know, again, this is left to the states. They've talked about their points of distribution. Where will they do it? What type of workforce will they pull in to help with this? That's really part of the whole preparedness planning that's been going on around the state and local areas, understanding which sectors can be brought out to help with different stages. You know, from our role at CDC, you know, an early decision is, do you deploy these assets? You know, at what point do you send them out because they become the state's or big cities' assets once we deliver them?
Are these
really flexible?
Do the drafters of these plans have to pay special attention for people who do not have health insurance and therefore do not have primary care?
Yes, there's a whole area of our pandemic planning around vulnerable populations, and that's a very important aspect of what the state and locals would be deciding. The issue is these are, you know, become state resources to distribute, not for reimbursement, just, you know, they give them out, but really focused on the treatment part. The states also have, most of the states also have purchased those same drugs for stockpiling for these types of reserves, and what we understand is we've distributed the materials. Some of the states actually are using them already. Some of them are holding them to see how things go because those drugs are commercially available.
It's a little self-evident, but it occurs to me that if you don't have health insurance, even if your state gets its fair share of these drugs, you have a pretty hard time accessing them, right? The school nurse, for legal and administrative reasons, probably is not going to administer them. You said the pharmacy. Well, of course, the pharmacy's not going to give them out for free, right? Are these prescription medications?
The antiviral drugs that we are providing from the Strategic National Stockpile are not to be charged for. The government has purchased those, either the state or federal.
Do you need a prescription to have one administered, though?
We used an emergency use authorization that the FDA signed off on in this context to be able to just distribute it without individual prescriptions. So for the context of an emergency, no. For routine purposes, absolutely yes, and we think they should be taken under a doctor's advice.
I raised this issue because the chairman and a good chunk of the staff here is spending an enormous amount of time on the health care reform issue, thank goodness. And this strikes me as yet one more compelling example of why we need every person in the country to have health care coverage. That anecdotally it appears, and I see my time is up, that the better your primary care is, the lesser effect this virus is having on people, and more primary care seems to be the answer. Thank you, Mr. Chairman.
Mr. Rowe.
Thank you, Mr. Chairman, for holding this meeting. I want to also fuss at the House of Representatives. We've done a terrible job. I've fussed since I've been here about no place for people who come into alcohol their hands off. We should do that in every hallway. It should be done months ago. So let's have this committee do something positive. And at least we shake hands with people from all over the country. So I'm just sharing a frustration, Mr. Chairman. If we can get that fixed, we'll have done something positive for the House of Representatives. I think back when I was a child at the polio epidemic and how that was managed and handled, a tremendous health care success. And to sort of defend, as a physician, to sort of defend the health care folks and the school director, what we plan, and as a surgeon, when I would go to the operating room, I planned on a train wreck and hoped I went on a train ride. You didn't know what the biological significance of this virus was when it came out, so we had to plan for the worst case scenario and hope for the best case scenario. It turns out that we overplanned, and I'm sure you recall, Dr. Shookount, the 1976, maybe not, I do, swine flu epidemic, that it turned out the vaccine was worse than the disease was. Well, we didn't know that at the time, and hindsight's always 20/20. And I think from a school director's standpoint, when it snows in Tennessee, where I live, 8 flakes, the school director calls school off and gets ostracized and so forth. But had you rather do that or have a bus wreck up in the mountains and hurt some children or potentially kill them? So you have a tough decision, and you're the ones that have to make that call, and I think the call was done appropriately here. Yes, it turned out this disease was not, or doesn't appear to be yet, as severe as we thought it was, but I think those preparations were extremely important. And to Mr. Andrews' comments, I called our EMA director. I went back in 2001 or 2 and got my smallpox because we didn't know at the time. And we have an EMA plan, and I'll call some EMA directors in our area and say, are you guys set to go, or is everyone ready? Yeah, we're ready. And we have a plan in our area to treat these epidemics. And I think that from 2000 and so, Homeland Security and CDC and so forth have made huge gains at being able to handle a problem as big as a pandemic, which fortunately this didn't turn out to be. So planning is very important. I'll share with you a brief story that occurred, and I won't mention which airlines, but this was when the smallpox scare in the early 2000s came along. A guy flew in from the Orient on an airline into Memphis, and they thought that he potentially could have smallpox. So what do the folks do? They keep him on the plane and send everybody else out. They sent 150 vectors out, and I immediately awarded them the Forrest Gump Award. As stupid is, as stupid does. So education has helped us, and planning in the last few years tremendously, and that's why, Ms. Brockhouse, I really appreciated your comments on planning, because it does allow us a way to handle these epidemics and pandemics. Could you comment on that from an employer standpoint, and how they did just your planning efforts?
I'm sorry, sir?
Your planning efforts that you've done in businesses and so forth, and I know the schools have done that also.
Well, first of all, I want to say in recognition of your frustration, Mr. Rowe, one of my colleagues, Judy Fryman, in our office in Sacramento, calls this a teaching moment. And when you were talking about, well, yes, let's do something here in the House of Representatives. So really, that's, I guess, the silver lining whenever there is an unhappy situation like a novel virus like the H1N1, whereas Dr. Schuchat mentioned earlier, lots of people suffered in many ways because of this outbreak, even though we're happy that it doesn't seem quite as severe as we thought it would be. I just want to say that to reiterate my point that planning in companies has to be include reaching out to the local and state health departments. And we have said that over and over again and have showcased the response in California because it seems so effective to us. And we've been directly involved with the California state and local variety of local health departments, many of them in California, and showcased those experiences to all of our member companies. These are large companies. You can imagine many of them have locations in all 50 states. So it's quite a hurdle for them to really reach out to the local health departments. California's really met companies halfway and more than halfway by initiating those outreach activities.
One brief comment about nursing. Again, Mr. Andrews brought up half the registered nurses in America can and will retire in the next 10 years. So it's not just in the school system, it's systemic, and we really need to train these healthcare professionals, and as Mr. Garcia certainly knows that very well. Thank you, Mr. Chairman.
Thank you. Mr. Hinojosa.
Thank you, Mr. Chairman. I thank you for calling this very timely congressional hearing on this issue that impacts the whole country and many, many other nations, but it especially impacts my congressional district because I had a hospital in Harlingen, Texas, deep South Texas, that received a child that came from Mexico with a family that flew in to the valley and were looking for second, third opinions. And that child then was moved on to Houston because of the complications, and that child died, one of the first ones, and Texas was charged with that one and first death. But just recently, a couple of days ago, we had a second person die in my area. She was living in Harlingen, a teacher who had given birth to a child just a few days before her death. And she was working in my school district of my hometown, Mercedes Independent School District. And so I say that it has hit us hard. And I have talked to the superintendents, I've spoken to some of the school board members, and they've all struggled with the decisions that they made in closing down the schools as they did several weeks ago. My question to you, Dr. Schuchat, is what is our country doing on collecting information on health of workers at healthcare facilities that have seen confirmed cases of H1N1, and how many healthcare workers have gotten sick?
First, I just want to say how sorry I am about what your community has gone through. I know that the families affected and the students in that environment have been through quite a lot. CDC is actively working with state and local health officials to understand the situation in healthcare workers. It's a very important population. We have detected a number of cases. I think yesterday it was 26 healthcare workers with the confirmed H1N1 virus, and we're actively investigating these to understand where they may have gotten the infection. Of course, wherever you work, you could also have gotten the infection at home or in the community or even while traveling. But we're also trying to understand the circumstances in the healthcare environment, whether they cared for anyone who had such an illness. The CDC has also been issuing guidance particular to healthcare workers to understand, how can they protect themselves while we're still in this situation of uncertainty. We don't have the results of the investigation of the healthcare worker exposures or illness, but it's an active priority right now in a number of areas, and it will be prospective, enrolling additional ones as well as the ones we've already found.
My other question is, what are the additional steps that CDC is taking to prepare schools like ours and childcare facilities for a potential pandemic?
With the switch from school dismissal guidance to recommending that schools reopen, based on local decisions as well, we have really built up a stronger partnership with the Department of Education to try to identify ways that the school environment itself could be an opportunity for teaching, for education about how to avoid these types of respiratory infections, as well as a place to emphasize recognition of children or teachers who are ill and encouraging them to leave and stay home until they're better. So we are continuing to try to make sure that the right messages get out and that we are taking steps to make sure we can keep kids in school where they can learn and keep children who are not well home where they will be able to recover before they return to the environment.
Thank you. I yield back, Mr. Chairman.
Mr. Courtney. Thank you.
Thank you, Mr. Chairman, and thank you for holding this hearing. There's no question, as the witnesses have said, that local and state officials in the area of school closings make the final call, but your direction, I think, is really what they look to. In Connecticut, in my hometown, our schools closed Thursday and Friday. My 14-year-old daughter says thank you, I guess, but but it was clearly driven by the initial guidelines. And one of the other ripple effects in terms of how school officials reacted, maybe overreacted, was that schools were then subjected to these pretty dramatic scrub downs. Local media was in there doing coverage, and certainly we want clean schools, but I guess the question is that really something that makes sense from a scientific perspective?
The environmental cleaning is important for some viruses that can live on surfaces for a certain period of time, with attention to the high-frequency areas, railings on staircases or doorknobs, elevator buttons, those types of things that lots of people touch. I do think that we have issued some guidance and working with environmental health experts at CDC as well as the virologists to try to focus the energy into the most effective steps. So I think that the media will cover something that's quite visible, but we do include in our guidance cleanup of the high frequency, the environmental surfaces that are touched a lot by lots of different people.
Yeah, it's really, I could care less about the media. The real question is just that, local school budgets, as Mr. O'Connell knows, are stretched thin. This is all overtime that was, generated as a result of this effort, and certainly being helpful to school superintendents in terms of trying to not go overboard would be helpful in terms of the right response.
Yeah, thank you. I think one big issue for us is to try to focus the energy in the most effective efforts and away from the ones that aren't really worth the trouble. So
Mr. Marjoleski, communicating with parents in these situations where dismissal has suddenly been issued and then rescinded. Again, I guess just losing my hometown. They shut down Thursday and Friday. SAT testing was Saturday morning, and parents were lost in terms of whether or not they should drop their kids off to come in for tests. What is the department recommending? Is it phone trees, email? How do you and how much do you tell them?
It's a good question. What we recommend is to communicate often, communicate with accurate information, and communicate in different modalities. This is not only that many schools have phone trees, but phone trees, text messages, placing it up on the web. I mean, a lot of the information that we've received from schools and schools put out is now web-based. I mean, it's a good way of doing it. Text messaging is also another way. And, you know, we've been working with schools since 2003 on what we call all hazards planning, making sure schools deal with a whole wide variety of hazards. And one of the things there that we've seen is that schools have built into their communication plans is getting messages out to school, getting messages out to parents quickly in a lot of different ways, and making sure that information is accurate. So those are the three things that we'd recommend to all schools.
I would encourage you to kind of keep pounding that message in terms of the department's communications to the localities, because you know, it was clear. Again, this happened so fast, and I'm not trying to, you know, Monday morning quarterback, but you know, it was pretty uneven. Let's put it that way in terms of how well that was implemented.
I think the other point that we've seen is that it's important to make sure that the information that's put out is accurate information, and it has to be accurate information. And if that delays the message a little bit, I think it's better to delay the message and get it right rather than to push it out and then have to resend it, because that just confuses parents.
I had one other question for Dr. Schuchat about the, you know, what happens to the flu virus when, you know, spring turns into summer, and then when it sort of bounces back in the fall. I mean, does it go into remission? Does it disappear? Does it migrate? I mean, why should we still really be concerned if the summer is coming?
You know, we'll be looking very intensively in the southern hemisphere our summer, which is their winter, because they, you know, whether they see a regular seasonal influenza or whether they see this strain that we've been having emerge as a dominant problem. So both in terms of support and assistance to affected countries, but also the scientific investigation that will help us anticipate our fall experience. We don't know. Some of the pandemics of the past have sort of simmered in the summer, but we are hopeful that the normal season will be on our side, because, you know, cases are continuing to increase right now. People sort of think we're out of the woods, but every day we're getting a couple hundred more cases. And some of it's the backlog in the lab testing, but new cases. So we're hopeful that as we enter the summer, you know, or primarily as we enter June, that we might be seeing a dampening here, but we really need to be prepared for this same strain to be around, or even have evolved a little bit to be in worse shape by then.
So if Southern Hemisphere countries aren't experiencing much this summer, is that a signal that we're not, you know, in a 1918 situation of a strong bounce back?
Yeah, that will be a good sign, but with influenza, you hate to say it, but it's very unpredictable. We have a lot of this virus here in the United States right now. Almost every state has it. And in the Southern Hemisphere, they haven't actually detected cases really yet. They're looking, there's a couple suspect ones, but their flu season's just beginning, and we really need to work intensively in partnership.
Gentleman's time has expired. We have a vote on what I'd like to do. I know members have questions. We're going to go to Ms. Titus next, but if we could limit it to 3 minutes, so you ask your first question first, and we'll see if we can get the members before we leave. It's Ms. Titus, Lobasak, Woolsey, McCarthy, Fudge, Hare, by Hare. Titus.
Thank you, Mr. Chairman. The Secretary mentioned that every state has a preparedness plan, and I guess that they submit it to you, and there's an appendix about schools. Well, I have a copy of Nevada's plan here. There are 13 agencies that contributed to the plan. None of those agencies is at all related to education. The Appendix A has 38 acronyms. Not a one of those is related to education. I've only found the word school twice in 76 pages. One is on page 40, where it says, for additional information on schools and healthcare settings, go to the CDC website. And the other mention of school is on page 58, and there it says other strategies for slowing the spread could include temporarily closing of schools, arenas, etc. I wonder if all the state plans are this bad, and if they are this lacking in coordination with schools, and if we don't need to do some review of what the state plans are. I appreciate the fact that there's more coordination now as a result of the new flu, but we had a potential pandemic several years ago when all of this was supposed to have been put in place, and none of the demographics or factors of this new flu are very different from those. So why is that missing? Why have we not done that before?
Well, it's a very good question, and there's two things going down on parallel tracks here. On the one hand, I want to repeat is that we have been working with school districts, primarily at the school district level, on developing and having schools developing what we call all hazards crisis plans. In 2006, because of the outbreak of the epidemic, or the potential outbreak of the epidemic in 2006, is we required that every school district receiving a grant from the Department of Education under our Readiness Emergency Management for Schools, and we provided funds to over 600 school districts in this country on that. We required them to have a pan-flu plan at the local level. So if you go out to the local level, especially for those districts that have received funding from the Department of Education and the preparedness grants, is that they have developed pan-flu plans. What you're talking about is a requirement which is not a Department of Education requirement, is a requirement which came down from Health and Human Services, part of a legislative requirement. And the appendix, I believe it's Appendix B4, is supposed to list education requirements, both K through 12 education as well as higher education, which is another appendix. We have reviewed all of those plans. Actually, we review those plans. We provide comments back to the states, and states were supposed to take the comments based upon our review and then revise those plans. We have not seen revised plans as of yet.
Thank you, Mr. Chair, and thank you for having this important hearing, and thanks to the witnesses. I'll be very brief. Dr. Shukett, I think you're at our bipartisan caucus, and I brought up the question of using the word swine, and I want to thank you again for not using that word, and all of you for not using that word. I'm from Iowa, and the pork industry is very important in Iowa, as it is in many states around the country. But on page 3 of your testimony, and you did mention this in your oral testimony, but you state that there's no evidence to suggest this virus has been found in swine in the United States, and there have been no illnesses attributed to handling or consuming pork. Currently, there is no evidence that one can get this novel H1N1 influenza from eating pork or pork products, and you mentioned that we should always cook pork products to 160 degrees Fahrenheit just in case. Can you be, I know you may not be able to answer this question affirmatively, but can you be less equivocal and state that one may not get this influenza from pork products? Because this language, I understand why you use this language. There's no evidence currently right now that anyone's gotten the influenza from pork. But can we go further than that and state that there's no way, if you will, that anyone can get this influenza from pork products?
People don't need to be worried about eating pork in terms of this particular virus. Influenza viruses can affect swine. Swine can become ill from influenza viruses, but everything we know about what's going on right now suggests you don't need to worry about pork in terms of eating that or handling it.
Thank you for going that far. I appreciate that, right? How are you getting the word out then about this and how it is the case that really it's not possible to get this from pork? How is the CDC getting the word out?
We've placed communication as our highest priority really in this response, because information and misinformation are important in how the public reacts and the unintended consequences. In terms of the pork issue, we've been working with both USDA and the Pork Board and other business concerns to understand what we can do to clarify the issue. Here in the U.S. it's an issue, and in other countries it's an issue as well, and we're really trying to be sensitive to both the cultural and economic impacts of our words.
Right. Thank you. I think it's for the record, I want to say I think it's very unfortunate that China and a number of other countries have banned pork imports from Iowa and other parts of the United States. It's very unfortunate. Mr. Marjoleski, have you or have any of you seen any who might Mr. O'Connell in particular, have you seen any cafeterias, school cafeterias banning pork products as a result of this?
We're not aware of any, sir.
Okay, good.
No, have not in California.
Good, thank you.
Thank you, Mr. Chairman. Certainly, our number one concern is the health of every American, everybody around the world when it comes to a pandemic. Today, we're talking about children and workers, and certainly one of the sure ways to stop an epidemic or a pandemic is for a sick child not to go to school and a sick employee to stay home from work. So we need to provide a series of programs to protect the worker from loss of pay and from a loss of any punitive retributions if they do stay home. So my question is to you, Ms. Brockhouse, does ORC support a paid sick leave and or paid family leave, family and medical leave plan, or any other plans that bridge work and family? And then, Mr. Garcia, I'd like you to think while she's answering me whether your employer has provided any of these plans or these benefits to their employees.
Well, Mrs. Woolsey, ORC's experience is really only with very large companies. And our experience with those companies, and we have some survey results we can share with you, is that more than 98% of the companies that we've surveyed are very large companies.
Well, do they pay have paid family leave so a parent can stay home with a sick child, or the worker can stay home when they're sick?
They call the leave policies by different names in many cases, and in many cases there is an amount of leave that's given that the worker has flexibility in terms of how to use. I'm really not competent to address the issue of companies that don't provide that leave.
Okay,
Sympathetic
thank you.
to the issue, but
Mr. Garcia?
Hi, thank you very much. And we do have as part of our, what Kaiser has, part of our benefits is sick leave pay so that someone can stay home, as well as FEMLA and CESLA, that if there was a need to stay home with a family member, then we can. And one of the things that you pointed on that I think is very important is actually recognizing that how do we stop the transmission of it. And right now, even when our emergency rooms is where I work and working with workplace safety as a labor co-chair, that we're seeing our emergency rooms very busy just with our normal cardiac and stroke. And as we continue to double, and even though we're at the beginning of this understanding of the flu, we are seeing a double of people being infected, confirmed, as well as actually probable cases. So being very familiar with the germ theory is that this is how we stop the germ from actually, or the virus from being contracted and transmitted, is by actually taking care of the worker, whether it be staying home, whether it be having standards that are put in place.
And with my I have a tiny minute left maybe, then you are using OSHA standards to prevent this from happening in the first place?
Oh, we do have policies in place that we are implementing, and as we prepare, we are communicating when they start. Yes.
Ms. Clark.
Thank you very much, Mr. Chairman. In addition to being a member of this committee, I also chair the subcommittee on emerging threats, cybersecurity, and science and technology for the House Committee on Homeland Security. It is in this capacity that I'm responsible for conducting oversight to ensure that the Department of Homeland Security is performing its mission of coordinating federal departments and agencies that are charged with responding to pandemic flu, and doing what is necessary to address and mitigate the spread of the H1N1 flu. I also happen to be the only member on this committee from New York City, and needless to say, I have a very special interest in this topic being discussed today, and I'd like to thank you, Mr. Chairman, and all of you who are contributing to this hearing today on this very important issue. I want to also take a moment to commend our Mayor, Michael Bloomberg, our Deputy Mayor, Linda Gibbs, our Health Commissioner, Tom Frieden, for their response, work, vigilance, and keeping New Yorkers informed and safe. My first question is to Mr. Bill Marjoleski and Jack O'Connell, and to you, Dr. Shokat. I have a significant immigrant population in my home district in Brooklyn, New York. For many immigrants, English is their second language, and quick and effective communications with immigrant parents is a key component to preventing and mitigating the spread of the H1N1 flu. and for future outbreaks. I'd like to know what, if any, outreach our educational systems and the CDC have done to get this information into immigrant communities.
That's a great question. First of all, let me say is we have worked very closely with officials, key officials in New York City, both in the city as well as with the Archdiocese School District, where you had a recent outbreak in the high school. There are a lot of populations that we're dealing with here. One of the interesting things is that we held, as I mentioned in my testimony, 3 outreach phone calls where we had well over 3,000 lines come in from people asking questions. And one of the questions that kept on coming up over and over again was about immigrant populations, not only those down by the border, but in other communities. And so what we've been trying to do is outreach, push information out from the Department of Education, not only to school districts, but to a lot of community groups and organizations that represent those particular interests. Also trying to ensure, and that's why we can't do it for every publication or every journal, is to try to make sure that the key pieces that we have are translated into key languages, especially, say, Spanish. And we're not the only ones doing this. I mean, part of what our philosophy has been is that we move forward in working in the community. I have to do it with Dr. Shuckett. I have to do it with DHS. And I should say is if you're looking at DHS, they've done a phenomenal job, I think, in coordinating overall efforts with all of the domestic agencies, including Department of Education.
Thank you very much, Mr. Chairman.
Ms. Davis.
Thank you.
Thank you, Mr. Chairman. Good to see you, Superintendent. I just have a very practical question, partly from the stories of bathrooms not being equipped with soap or sanitizers. Is there some reason why we shouldn't have sanitizer dispensers in classrooms? Would that be overreach? Is that necessary? Would that be a good idea, generally, in terms of educating students to use them? I know whenever I go anywhere, people are always dousing me with, sanitizer. And so just wondering if we shouldn't sort of look into that being usual fare for our classrooms.
Congressman, nice to see you again. I think that's a very good idea. It comes down to an issue of funding and priorities for our schools and the strapped budgets that we have, the inadequate number of school nurses, and I believe that this issue has really called that issue front and center. And a point earlier, the shortage of nurses that we have, not just for schools, but also for our general population, is going to be a real challenge for us. And that's why the posters, to go to Congresswoman Clark's issue, we have posters in California, as you know, multiple languages, very diverse student population. 48% of our students are Latino. 40% of our kids go home from school, speak a language other than English. 39% of our kids came to school today to learn the English language. And 1 out of 4 students, K through 12, came to school to learn the English language. So we do have to make sure that we, multiple languages, and that we try to meet those basic health care, good hygienic policy.
Right, absolutely, but it's partly habit forming, and it just occurs to me sitting here, and I wanted to wait and say hello.
Good.
Thank you very much.
Point. Thank you.
Thank you very much. Just if I can have a couple of questions here. This question of what do the interplay between employers and schools is rather significant, obviously. And so for the moment, we've kind of dodged a very serious situation. And yet, people may have to make decisions to go home to take care of a very ill child or a family member, or they can't get the child to school. And, we have a system sort of built up with, there's various sanctions. If you don't show up for work, the theory is you're not doing your job, you could be fired. If you don't show up for school, you can't take the test, you can't go ahead, you lose your ADA. There's all of these things that are built into the system that assume regular order every day. And yet we see, and I think the CDC has suggested and science has suggested, that we can expect a continuation of this trend toward something like a pandemic. It may be dangerous, it may not be dangerous, but it's going to be upsetting to the economy, to the school environment, to society. And I just wonder, now that we've had a bit of experience in terms of a very large scale, where, in the county I represent, we had 5 school closures, and that kind of shook everybody up, and other people were wondering if they should close. But are we starting to look at how we make these decisions and whether sanctions, the traditional sanctions that are sort of institutionally in place or culturally in place, whether they help us in dealing with the pandemic, or they're a hindrance to it? I mean, it's tough. You're an employer. You got product. You got to move. You got guidelines. You got contracts. You got commitments. And the other people on the other side of those contracts may not be experiencing any of this. What are we thinking about this in the larger sense? Start with the CD, because I know you have to go, and I know you all want to go. So I'm not going to keep you very long. But Dr. Shukate?
You know, I think the issue you raise is incredibly important. In our pandemic planning, we had identified certain policy issues that would need to be surfaced that, you know, hadn't really been settled as we were thinking of the science or the public health impacts. We did actually public engagement around the question of what we call community mitigation. These issues like closing schools or making people telework, or, you know, really shutting down social distancing, canceling big gatherings. And some of the comments from the public citizens involved were about these matters. You know, will I be able to, you know, what's my employer going to do? Can I get forgiveness on my mortgage payments if I've got to, you know, not work for X amount of time because of these new policies? I think these are really important issues, and I would say we probably have a chance to learn from the experience that we've gone through.
It's how people make decisions, but I don't know that we have a set of clear signals about your interests versus your traditional societal interest that come into conflict. I don't know. Yes.
Yeah, this is not specifically an OSHA issue, but it is certainly a Department of Labor issue. When we're dealing here, part of the public health strategy is to get people to stay home if they're sick or if family members are sick. Obviously, if people don't have sick leave or don't have other income support, they're not going to be able to do that. They're not going to do it, and that's a problem for the public health. We have at the Department of Labor identified a number of really holes in the social safety net that deal with income support, job retention, FMLA issues that don't necessarily apply to this situation, and it is an issue of great concern for us, and we are in deep discussions within the Department of Labor and with the White House on how to deal with this should we come across a really serious pandemic.
Jack, you got teachers that, what do they do?
We do, and the example I was thinking of, Mr. Chairman, is there's a large hospital in Santa Barbara, and of course we're all thinking of them for the bad fire there right now, but in Santa Barbara, the secret to that hospital's success has been they were able to provide child care. You know, a predominant number of their employees are women, many single women, many with kids, and the child care that they provide, they also have a segment for if their child is sick. And it's the only one that I'm aware of. If your kid is sick, we still want you as a nurse, as a doctor, as a LVN to come to work, and we're still going to take care of your child. And I say that not from the healthcare perspective, but as the employer community. The hospital's a for-profit institution, and I think that's really helped them with their.
But the traditional child care center is just almost the opposite. You want the kid to stay home, I assume.
And this is the exception. That's exactly right.
Yeah. Let me ask, Mr. Garcia,
And Chairman Miller, I wanted to just mention as far as our labor management partnership, the things that are working with Kaiser Permanente that I'm finding, I'm hired by them as a contract specialist to actually allow the healthcare worker to have a say, and we have something called the unit-based teams that monthly we do meet, and every department is responsible, and our contract is over next year and are reiterated, but we are supposed to, each department, to actually have a unit-based team that there's an equal say between labor and management. Because I feel like that one of the factors is, does the actual healthcare worker feel protected by the employer? And for one of the things that I feel like is working in our community, in our hospital, is that of a unit-based team and a partner laborship management. And I'm actually there to actually make sure that that culture is understood, whether it be from the management or from the labor, to say, are we abusing this, or are we not allowing the culture of that you could stay home if you need to? If it's something is unfair, I go there and I represent them. And so I feel like that's one of the things that is working, is a labor management partnership.
Let me ask you this question. I had a chance, sort of in the middle of all this, to visit a large medical center on an emergency basis. And so I was there for a couple hours, and of course I'm always amazed at how fluid the medical staff moves through in and out of patients with all different set of circumstances. But you know, people weren't wearing masks, they weren't wearing respirators, they were just taking care of the patient population. how do those institutions make the determinations that you ought to move to a level where you should be wearing a mask or respirator or this? What's the guidelines that are there?
We showed you the risk pyramid there. We really expect employers initially to do their own risk assessment. They need to decide who is at risk in their environment, and in this case, again, who has direct contact with infected or suspected to be infected individuals. Now, this shouldn't be anything new for hospitals. As you know, there are a variety of hazards that exist every day in hospitals, pandemic or no pandemic. Hospitals, we expect, should have some kind of health and safety program there where they're making these determinations constantly about either infectious disease hazards or chemical hazards that workers face. So we expect them to apply those same principles to the pandemic flu situation.
But I mean, I'm watching, sitting in the waiting room, I'm watching the person that's doing the initial intake. She's talking to families. Somebody in the family is sick, but the whole family wants information, but they're gathering around her and they're talking to her and they're trying to determine, in some cases, a member of the family is interpreting for them. And this intake worker, I don't know if she's considered medical staff or where she fit into that process, but she looked to me like a frontline individual. So but you're saying that's handled based on the institutional decisions?
Well, partially. I mean, when you get down from the very high risk or high risk to what we might consider medium risk people, which may be workers who come across a lot of people every day, and those could be the intake people. They could be supermarket checkers, for example. You're dealing with a whole lot of people. Now, the precautions they need to take will be determined by how severe the virus is expected to be or is, and how pervasive it is. And those, again, we get our cues from CDC. In this case, it wasn't very serious, and it wasn't, as pervasive, and therefore we weren't dealing with the precautions that some of the middle risk workers have to take. But that could change.
If you're a grocery store, you probably don't want your checkers wearing a mask.
No, exactly, right.
But, so what's the set point for that decision? Do they have to be directed by CDC, that if you come in contact with large numbers of people where the influenza is geographically, you can say it's here because of the level of infection? Who makes that decision? Because there's a lot of public relations reasons why,
we look to the scientific information about what's going on, what type of transmission routes there are. Here we're mainly thinking of what we call respiratory or droplet precautions that are needed in that healthcare environment, and nothing really needed at the supermarket. But infectious diseases are different and the circumstances will vary. I just want to make the point that there's certain protection that workers in the healthcare environment can take every year against the seasonal influenza strains that are also spread sometimes in healthcare settings. And unfortunately, even with that 36,000 deaths a year that we have and a lot of vaccine that's very effective, only about 43% of healthcare workers take advantage of the seasonal flu vaccine each year. So in terms of those teachable moments, there's a lot that healthcare workers and hospitals could be doing to protect workers day in and day out in the annual flu.
In your continuity plans, what do workers do if 10-15% of their workforce has kids home sick? They have influenza, but you don't know at that point whether it's very serious or not. They've been told the school's been closed. What do employers?
Well, I wanted to make the point that one of the things that we found companies doing is developing questionnaires so that they could screen employees. Companies who work definitely want sick workers to stay home, but it was tough. This is seasonal seasonal allergy time. Is your runny nose from H1N1 or is it from allergies? So companies developed questionnaires, told sick workers to stay home but call in and have somebody run through a questionnaire. And the companies were very dependent on the description of the virus and its symptoms from the CDC. So questionnaires were developed based on the specific characteristics of this virus, trying to figure out who are the right people to keep at home. And it's so I just want to do another hats off to the CDC for providing that information. And the companies were so interested in these questionnaires that more than 20 companies shared their questionnaires with us to make them available to other companies so that they could learn from those questionnaires. And we're going to post those on our Center of Excellence website, which is on our public website.
Well, thank you very much for your time and your testimony and the expertise that you brought to this hearing this morning. There still remains some pretty serious questions in these large institutional responses, especially if this is something, unfortunately, that we can continue to look forward to. We're strains that we don't know a lot about in the beginning, and we don't have real bright lines exactly what people should or should not do. It's a real test for certainly for schools. I think it's a very real test on how they cope with that, because again, you have deadlines and systems of financing. But thank you so much. And with that, without objection, members will have 14 days to submit additional materials and questions, and the hearing will stand adjourned.